Greetings. Let us learn about how to manage a patient with esophageal variceal bleeding in the setting of cirrhosis of liver. Uh, Medical management is really critical, and how do we go about doing that? These are my acknowledgements and a notice for you to read. So here is a lady who was diagnosed with alcoholic cirrhosis, and she comes in with hematemesis. We all know that during the COVID pandemic, alcohol intake has certainly increased, and that has certainly caused quite a bit of problems. So, when you go to the bedside, keep in mind ABCs of resuscitation: airway, breathing, and circulation. And when a patient with cirrhosis comes in with hematemesis, it's important to keep in mind whether that patient requires airway protection or not. And how do you figure out that? Look at the sensorium. If the patient is alert, oriented, times 3, and has no confusion, and able to take care of the secretions and vomitus, that patient does not need airway protection, but you need to keep an eye on that patient to see if the status changes and your decision to withhold airway protection may change. On the other hand, if the patient is drowsy, when you look at her orientation, disoriented, or comatose, that patient needs airway protection, and it's important to consider endotracheal intubation to prevent aspiration. So, you do not want to have a patient who comes in with a bleed, already a major problem, and by not taking proper precautions, the patient ends up with aspiration, and you have two problems now. One is the bleed, and the second one is aspiration pneumonia and possible respiratory failure. So, something to keep in mind. The next is circulation, and important to resuscitate the circulation. Important to put in at least 2 large bore IV needles. Best is to put a shorter, wider bore angiocath so that you can pump in fluid to resuscitate the patient if necessary. Unlike peptic ulcer bleeding or non-variceal bleeding, in patients with variceal bleeding, it's important to keep in mind the fact that if you resuscitate the patient aggressively, pump in a lot of fluid, give in a lot of transfusions, that increases the portal pressure and it adversely impacts the outcome of that variceal bleeding. So keep in mind when you have a patient with cirrhosis which comes in with hematemesis, before you jump in and try to give a lot of blood, check the hemoglobin. And if the hemoglobin is above 7 grams per deciliter, and as long as the patient is not actively vomiting blood, you could restrict the transfusion. On the other hand, if the patient bled and the hemoglobin is 6 or so, then transfuse packed red blood cells with a goal to bring it to 7, as long as the patient is not actively losing blood. So that is something you have to keep in mind. And the rationale is to limit splanchnic vasodilation from aggressive pumping in of packed red cells. So very important to keep in mind. If you do that, you're basically worsening the portal hypertension, and you will not be able to control the bleed with worsening portal hypertension. So restrictive transfusion to a target hemoglobin of 7 is something you have to keep in mind. Patients with cirrhosis also have some coagulopathy and may have thrombocytopenia, and these don't need to be corrected. And make sure you avoid unnecessarily giving routine orders for fresh frozen plasma or cryoprecipitate or platelets. These tend to increase the volume of the patient, increase this effective circulating volume, which in turn increases the splanchnic congestion, worsening of portal hypertension, and an adverse impact on the bleed. So these are the two important principles. Limit unnecessary expansion of splanchnic congestion by restrictive transfusion to a hemoglobin of 7 and avoiding routine orders for fresh frozen plasma, cryoprecipitate, and platelets. Then you want to figure out a way to uh, decrease this splanchnic congestion by giving vasoconstrictors or vasoactive therapy. We have three options: octreotide, somatostatin, and terlipressin. So let us take a little bit of time to learn about how do you give octreotide, how do you give somatostatin, and how do you give terlipressin. When it comes to octreotide, that's what we use here routinely. We start with a bolus, intravenous bolus of 50 micrograms, followed by an infusion, a continuous infusion of 50 micrograms per hour. That's what I do. And you give it for at least between 2 to 5 days. When it comes to somatostatin, the bolus is 250 micrograms and then an infusion rate of 250 to 500 micrograms per hour, again for 2 to 5 days. When it comes to terlipressin, this is given as a bolus, IV, 2 milligrams every 4 to 6 hours for the 24 to 48 hours, and that's what we give. IV 2 milligrams every 4 to 6 hours for 24 to 48 hours. And then after the 2 days, you reduce the dose to 1 milligram, again every 4 to 6 hours for another 24 to 48 hours. So, in addition to this, we should also keep in mind with splanchnic vasodilation, there is always going to be, after a bleed, bacterial translocation and risk of infection. So you want to give prophylaxis against infection that has been shown to improve the outcome of these patients. So we give them ceftriaxone intravenously, 1 gram every 24 hours. We give the antibiotic for at least 5 days. So let me recap what we have learned. When a patient with cirrhosis comes in with hematemesis, you assume that it is variceal bleed. And until you document that it is not variceal bleed, the management principles are always the same. Make sure you do something to protect the airway. If there's a concern about aspiration, keep that thing in mind, which is a top priority. And then you start octreotide, the vasoactive therapy. Other options we reviewed are sandostatin, terlipressin. And when it comes to octreotide, IV 50 micrograms bolus, followed by an infusion of 25 to 50 micrograms per hour. You continue for at least 2 to 5 days. Do not forget giving an antibiotic. In cirrhotic patients, the antibiotic of choice is intravenous ceftriaxone, 1 gram every 24 hours. These two things, octreotide and ceftriaxone, as you can see, the plus green mark is I'm putting these things for you to think traffic lights. Green is to go. Octreotide and ceftriaxone, every patient should get it. Regarding the transfusion, keep in mind the benefits of restrictive transfusion, not aggressive transfusion to pump in whatever you want to pump in. The goal should be restrictive transfusion to 7 grams per deciliter. Unless the patient is vomiting in front of you and you worry about significant blood loss, in that case, it's a different way to manage. They require products, you give products. But otherwise, if the patient has bled, looks like the patient bleeding stopped, don't aggressively transfuse fast, large volumes, which will increase the splanchnic congestion and the bleed will continue. And then the red mark in the here is avoid unnecessarily giving fresh frozen plasma, cryoprecipitate, and platelets. So we have covered a lot of stuff. With this, we should be able to stabilize the patient and we should plan for endoscopy typically within 12 hours. I hope this is helpful and I want to thank authors of this guideline. You could take time to read this and thank you.